Hello, and welcome to our second webcast on patient safety. My name is Jeff Terry, and I'm a managing principal with GE Performance Solutions. The title of today's discussion is Safety and the C-Suite, Leadership's Role in Safety Transformation. After the discussion, the panelists and I will be live over the telephone to take your questions. There is a Q&A tab on the lower right side of your screen. There you can submit questions for our guests that we'll answer later. In our last discussion, we tackled the topic of hospital culture around patient safety. At the end of that first session, the audience voted on our next subject, and the role of leadership emerged as the hot topic. I think we'd all agree that leading a hospital through culture change is a difficult task. Each action and message from the leader helps to shape the environment. How do you help a team become self-accountable? How do you deal with blame and punishment when an error is committed? These are the challenges that we face, and they are complex. And while the challenge remains significant, there are many successes that cannot be ignored. For example, at Mount Sinai in New York, clear leadership from Wayne Keithley, their president, has made an impact. Wayne made establishing a learning culture central to their work in safety. Over time, frequent and honest communication about what was being learned from event reports led to a dramatic increase in event reporting at Mount Sinai. With this large data set and an evolving culture, Sinai has begun to make even greater strides in patient safety. This is just one positive example. Another provider that has emphasized patient safety is Catholic Health Partners, based here in Cincinnati. I'm excited to get the perspective of two of their leaders today. Catholic Health Partners is the largest healthcare system in Ohio with 38,000 associates and 34 hospitals. They were named a top 10 health system by Thomson Reuters and have also been recognized by the Joint Commission Journal on Quality and Patient Safety. Joining me today is Jane Durney Crowley, Executive Vice President and Chief Administrative Officer of CHP. Her responsibilities include, among other things, oversight of quality and patient safety. She's been with CHP for 11 years and led the development of the system's full strategic and annual planning architecture. During her term, CHP has consistently achieved top quality performance on acute care quality metrics. Thanks for being with us today, Jane.
You're welcome. Good morning.
Good morning. We're also glad to welcome Stephen Grossbart, Chief Quality Officer of CHP. Steve oversees the Patient Safety and Clinical Transformation Department. His team focuses on system-wide efforts for clinical quality, medication safety, and process redesign. He's a frequent presenter of research at meetings for the National Patient Safety Foundation and the IHI. Steve, we appreciate your being here.
Thank you, Jeff.
And so with that, we'll get started. And I think, Steve, I'll start with you. The first question that I want to ask is right at the heart of this, which is leadership ability. So in your mind, what skills do leaders need to continually focusing on developing in the battle for patient safety?
Well, in Catholic Health Partners, one thing we have done is created a leadership academy. We call it the Patient Safety Leadership Academy, and all of our hospital presidents participate in this academy. And we focus on leadership, the ethics of leadership. We've trained our hospital presidents on patient safety walk-rounds, on disclosure, on assessing and managing serious events. So there's a wide range of skills that leadership is expected to have, and we've done our best to provide our hospital leaders with the tools to be successful in that area.
And I think the Leadership Institute's at the center of that, but CHP is a large organization, so how have you made that practice common across the organization?
Well, one thing we have done is we do have our hospital presidents meet in a regular monthly conference call. And this is a good opportunity for the presidents to share with their peers the challenges, the opportunities, to bounce ideas off each other, and has created a real camaraderie among the hospital presidents who span 5 states. So now there's also an inclination for those presidents to cross state lines by picking up a phone or sending an email. So creating that community of hospital leaders has been very important. That collaboration and sharing is critical.
Yes, thank you. And Jane, can you talk about kind of on that same thing, how leaders collaborate with their peers and what you think is important in that vein?
Well, out of the academy, as Stephen said, we've seen really a cohort or almost a club develop so that they have each other's back. And so what we'll find is even outside of the scheduled calls, one CEO will call another and say, I had an unfortunate event in the ICU or the OR yesterday. Here's my plan. Here's what I intend to do. Do you have any advice? I remember from the report that you've had similar events. This is a safe setting for them. They're not calling their boss. They're not calling their board chairman yet. They're not facing the press. They're going through in their mind what their action plan is and getting advice from another colleague. I think if we had not set up, or actually they set it up, this safe monthly phone call, and those relationships hadn't begun to develop, in a vulnerable way, the basis of the phone call, right, is to tell each other about some untoward event that's occurred in their hospitals or some difficulty or resistance that they're having in changing their culture. So it's it's intentionally private, and it's a place where they have learned to handle these events and the culture of safety. And it then translates into ongoing assistance offered to each other on an ongoing basis.
Absolutely. And on the calls, that's the hospital president, CEO, it's the kind of the audience on the calls.
Yes, it's just the hospital presidents. In some cases, they have multi-site responsibility. Their title might be chief operating officer. It depends on the size of our regional health system. But they are the top leader for one or more hospitals. And so they're really on the point in terms of this change from an environment where error and harm was understood by administrators and clinicians to be a normal part of acute health care to an environment where we don't accept that errors have to be part of modern health care, and we are working every day to reduce those errors and to find means to prevent them. It's been instrumental that they take the lead in this work. Our quality teams, our quality department teams are the coaches, the tools, they provide the intervention methodology, but the leaders have to lead. They have to change the way they manage the institution for the change to take hold.
And what a great message it sends that it is the leaders, and it's known.
It is the leader's responsibility. That goes back to the ethical. When we started the academy, the first talk was by an ethicist, and it was about the ethical responsibility to lead for safety, that it was the first responsibility of the CEO, and it was non-delegable. That's not the core curriculum in business school. At least for many of us, it wasn't. You learn the basics of running a healthcare organization as a business, and you learn very little, frankly, about clinical medicine, and even less about how to make our environments safe and reliable. And so we felt that we had to balance that by creating the curriculum and taking the team through it in an organized way, and not to assume that they knew how to do a better job, because it's a new job. It's a job that all of healthcare, all the hospitals in America are learning how to do.
And you mentioned earlier this idea of stand downs as in a reaction to a specific event. Can you share those with our audience?
We have a hospital president who has a military background himself. He was a JAG officer. And he noticed was involved in the review of a series of unfortunate events in one of our large teaching hospitals. The events themselves were unrelated, but what occurred to him is that a few of those events in such a short period of time, I think it was 2 weeks, was very surprising and was a huge concern to him. And he recalled his Navy training, and he decided to do a stand down, which an admiral would do if there was a problem on a ship. And so he literally took the organization through, in a short period of time, department by department, unit by unit. He disclosed the events to them and described what the organization had learned. He admitted that the organization provided care that was less than error-free, not as good as it could be, which I think the admission alone was a very important cultural moment. He asked the teams what they thought on their unit were the greatest risks, and what were they doing about it and what help did they need. And he reviewed the principles of creating a highly reliable organization: just culture, transparency, standard protocols, good communication, and the ways to report problems using our electronic reporting system, so that safety came back up to top of mind in each and every clinical area. To my knowledge, it had never been done, and it sent a very clear message that safety is job one.
That's terrific. Thank you very much for that. So, Steve, another obvious role of the leader is measuring success. So I want to turn our attention a little bit to how do we know that we're making a difference. So, and of course, your role, you sit atop much of these efforts. So, what are the benchmarks that you focus on, and how do you manage them?
Well, benchmarks are useful in the sense that they help us understand opportunities and where they might exist. But it's important to also keep in mind that benchmarks aren't an end in of themselves. So, for example, a great story is we set out in 2008 to reduce preventable mortality in our hospitals. In that, as we were establishing our goals, there could have been two different approaches. One approach would have been to pull one of the national databases, look at our performance relative to the national database, identify what a top quartile performer is performing at. So if we are below the top quartile, we set the goal for top quartile and see if we, and then measure ourselves at the end of the year. That's one approach. Problem is that often your top quartile performers have preventable mortality that occurs in their walls. And using the benchmark as a goalpost is maybe not the best way to get at improving quality and safety. We instead had each hospital review using a tool called the Institute for Healthcare Improvement's 2x2 tool, diagnostic tool. Look at each one of their mortalities. We had them pull 50 consecutive mortalities and then estimate how they should reduce, where the opportunities are, how they should reduce mortality. And they set their own targets. So every hospital had a target, improvement target based not against a benchmark, but rather against where they are today and where they believe they can get to tomorrow. And we had a rocky start. Some of our hospitals actually couldn't find any preventable mortality, yet they had the highest mortality rate in our system. And that was a cultural issue. They could not recognize preventable mortality. They didn't believe it existed. So culturally, we learned that you can't fix what you can't see. Mm-hmm. Other hospitals were very aggressive at identifying through the chart reviews preventable mortality and set very aggressive goals and met them. So that was an important learning for us, and we've continued that. We've done our learning collaboratives similar to the Patient Safety Academy, but focused for the frontline leadership in the hospitals, where we've started working on areas where we know we can reduce mortality. And we've seen a pretty remarkable drop in mortality. Just this last year alone, we estimate that 340 deaths did not occur in our hospitals because of improved end-of-life care, early recognition of sepsis.
Which you touched on that seminal point that you talked about, which was openly acknowledging, discussing that this was preventable, and then that has to be cultural. Mm-hmm. You mentioned the Patient Safety Academy. Can you describe the setup of that a little bit for our audience?
Absolutely. So we have, since the fall of 2006, we have held 2 Patient Safety Academies each year. And we invite all of our 34 hospital presidents. Sometimes we open it up and include the chief nursing officers and chief medical officers to attend the meetings as well. We typically bring in, each one is different. It's not a standard curriculum. And we typically bring in a national leader, expert on some aspect of patient safety, as well as using it as an opportunity to share success stories within the organization. The topics have, as I mentioned earlier, the topics have included training around patient safety walk-arounds. Most recently, we had a conversation about leadership by Stephen Spear from MIT and a senior fellow at Institute for Healthcare Improvement. Alan Frankel has come in and spent a lot of time working with us. So we've had a number of pretty prominent, dynamic national speakers on patient safety. And again, that collaboration, that conversation that emerges out of these meetings is critical.
Oh, that's great. Thank you. And I'm curious, one of our next sections are on safety and cost. I'm curious how, Jane, from your perspective, how has the organization justified the cost of bringing together all those people twice a year? I mean, clearly it makes sense, and yet there are always cost pressures. So you can comment on that balance?
Yes, there certainly are always cost pressures, and every time we design and implement a new collaborative, it requires our executive management team's approval. So the business rationale is that harm is expensive. Harm almost always significantly increases the cost of care delivered in an admission, even if you stop at the admission itself and don't count things like harm to your reputation or harm to the growth of the service line or harm in that clinicians might choose not to work in an environment that they don't feel safe. Even if you only count the very tangible costs of extra days in the hospitals, extra supplies, extra testing, extra time in the ICU, even if you only count that, Stephen has shown that we not only don't make money on those cases, we usually lose a dramatic amount of money on cases where the patient's stay has been extended because of harm. So that's one way we can measure that. The other way, and I'll use our perinatal service as the example, as is true in most health systems, your OB service accounts for 40 to 50% of malpractice claims. The truth is that many birth injuries, usually neurologic, are preventable. Care in obstetrics across this country until recently has not been very standardized. It has not followed the evidence closely. And we began a journey, 2005 at least, of serious adoption of the ACOG-approved protocols for care in the OB units. And we've seen a 60% reduction in our cost of claims related to obstetrics. And we see it both in the number of babies that are harmed and in the number of suits that are brought, and certainly in the dollars settled. That kind of hard evidence that safe care is financially practicing good stewardship, that kind of feedback loop to our executive teams has been very powerful. In and of itself, it's not enough to finance the infrastructure, but it's evidence that to our executives that what we're doing is working. That when Steve's team brings, for OB, we bring 125, mostly clinicians together now annually, because they're through the intense part of their collaborative, that the results will be better care, and that one way that's measured is through our malpractice trust. So I don't want to say that we justify all these events or all this work based on a very clear ROI, but it helps to have the ROI be proven, at least in a number of situations. The other thing we did that helped a lot is that we, as the cost of claims came down, we diverted some of those resources. We lowered the cost of malpractice insurance to the hospitals, but we also reserved some of the delta to fund some of these transformation activities. So the hospitals did not see an increase in expenses, overhead expenses for Steve's central staff, his support staff. Net, they still saw a slight decrease, even as we shifted from funding errors or damage, if you will, to funding prevention. And that has been a strategy that has really worked for us, because he doesn't have to go to the well for incremental new resources very often.
And that takes the form of a reduction in their insurance premiums to
Correct.
the self-insured. And meanwhile, you're able to reserve a little bit for continued
Correct.
investment. So everybody.
Correct. And we can invest in the next initiative while the ones that are already up and running, I think you're on 6 or 7 separate collaboratives that begin to bear fruit.
Oh, that's fair. Thank you. And as we were chatting earlier, what struck me, the OB example is terrific, but it rests upon this infrastructure, this organizational capability you have about learning collaboratives. So you have a vehicle and a methodology to go do things like that. Can you talk about that?
Jeff, we're running multiple collaboratives right now. Next week we're going to bring about 150 clinicians from across our system to focus work on emergency department. We've already had a collaborative around improving patient experience and another one about reducing readmissions just since the first of the year. We are probably averaging one collaborative every 6 weeks. Each collaborative has typically two sessions a year. So our topics this year include readmissions, emergency department. We'll have an annual meeting of perinatal, and then another session on high-level mortality harm reduction. And we're exploring and developing curriculum for behavioral health. These are all basically hot topics